Hi everyone, welcome back to your third video. In this video, we will discuss the clinical pharmacology of adrenocorticosteroids. The most common clinical use of corticosteroids is a replacement therapy, especially in acute and chronic adrenocortical insufficiency. Let's talk about the chronic adrenocortical insufficiency first. The Addison disease is the primary adrenal insufficiency due to the problem with the adrenal gland, or known as adrenocortical disease. This primary adrenal insufficiency is associated with both cortisol and mineralocorticoid deficiency. Thus, the treatment consists of hydrocortisone 20 to 30 mg daily and supplemented with the mineralocorticoids consists of fludrocortisone. However, please do not use dexamethasone, which is the long-acting glucocorticoid and it devoid of salt-retaining activity. The hydrocortisone or prednisolone dose should be divided 2/3 in the early morning and remaining 1/3 in the afternoon to mimic the cortisol level in the circadian cycle. In contrast, secondary adrenal insufficiency is due to disorder of the pituitary glands, which are unable to secrete the corticotropin secretion, or known as ACTH. And the tertiary adrenal insufficiency is due to the hypothalamus unable to secrete the corticotropin releasing hormone, or known as CRH. Please bear in mind that the secondary and tertiary adrenal insufficiency are associated with cortisone only, not include the mineralocorticoid deficiency. Because of, as mentioned before, the aldosterone, which is the natural mineralocorticoid, is regulated primarily by the renin-angiotensin system, which these are independent of the hypothalamus and pituitary. Thus, do not administer fludrocortisone in the treatment regime. For acute adrenocortical insufficiency, or known as adrenal crisis, the treatment must be instituted immediately once we suspected any case of acute adrenocortical insufficiency. The acute cortisol deficiency can happen due to the pituitary infarction or after surgical cure of Cushing syndromes. This adrenal crisis may also occur in patients who are abruptly withdrawn from exogenous glucocorticoids. You need to remember that prolonged steroid therapy has suppressed the HPA axis. It is because these exogenous corticosteroids depress the secretion of CRF as well as ACTH. Thus, it will inhibit the secretion of endogenous glucocorticoids, which can potentially causing the atrophy of the adrenal cortex. If therapy is prolonged, it may take some months to return to the normal functions when the drugs are stopped. Thus, we need to taper down the corticosteroid dose to avoid any adrenal crisis to happen. This adrenal crisis can be detected by clinical laboratory data, which patient will develop hyperkalemia, or known as too much potassium level in the plasma. Besides that, patient also can have hyponatremia, which lowers the level in the plasma. This hyponatremia occurs because of the mineralocorticoid deficiency and also due to inappropriate secretion of antidiuretic hormone, which is the vasopressin, that will cause by the cortisol deficiency. In this patient, combination of mineralocorticoid deficiency and glucocorticoid deficiency will lead to urinary sodium loss, plasma volume depletion, which will increase the serum urea. Thus, the therapy consists of large amount of heavy hydrocortisone, corrections of fluid and electrolyte abnormalities, as well as treatment of any precipitating factor. Hydrocortisone in dose of 100 mg were given IV every 8 hourly until the patient is stable. Then, the dose will gradually reduce, achieving the maintenance dose within the 5 days. The administration of the salt-retaining hormone can be resumed when the total hydrocortisone dose has been reduced to 50 mg per day. Congenital adrenal hyperplasia is a condition that characterized by deficiency one of the enzymes that needed to make cortisol and aldosterone. The most common defect is decreased or lack in the cytochrome P450C21 that responsible to promote the 21-alpha hydroxylase activity, which will lead to a reduction in the cortisol synthesis and thus produce increase in the ACTH release. This will cause the adrenal become hyperplastic and produce a large amount of 17-hydroxyprogesterone. This will lead to be diverted to the androgen pathway, results in genitalia in the female fetus. Infants with congenital adrenal hyperplasia may be in acute adrenal crisis and should be treated as mentioned before, using the appropriate electrolyte solution, intravenous preparation of hydrocortisone in the stress dose. Once the patient is stabilized, the oral hydrocortisone about 12 to 18 mg per meter squared per day in 2 divided doses, 2/3 in the early morning and another 1/3 in the late afternoon. The dose should be adjusted to allow the normal growth, bone maturation, and to prevent androgen excess. Fludrocortisone 0.05 until 0.2 mg per day should also be administered by mouth with added salt to maintain the normal blood pressure, plasma renin activity, and also the electrolyte levels. Cushing syndrome is due to tumor or nodular hyperplasia of the adrenal gland or ectopic production of ACTH by other tumor. The manifestations are those associated with the chronic presence of excessive glucocorticoids. When glucocorticoid hypersecretion is marked and prolonged, you can see a rounded plethoric face and trunk obesity. You also may be able to see muscle wasting, thinning, purple streak, and easy to bruising of the skin. The poor wound healing and osteoporosis due to the loss of the protein. This disorder is treated by surgical removal of the tumor producing ACTH or cortisol, irradiation of the pituitary tumor, or resection of one of both adrenal. These patients must receive large dose of cortisol during and after the surgical procedure. Dose of up to 300 mg of soluble hydrocortisone may be given as continuous intravenous infusions on the day of surgery. The dose must be reduced slowly to normal replacement level since rapid reduction in dose may produce the withdrawal symptoms including the fever and joint pain. The usefulness of corticosteroids is their functions of their ability to suppress the inflammatory and immune response, as well as they can alter the leukocyte functions. They can be formulated in the eye preparations to treat the ophthalmic diseases such as allergic conjunctivitis, keratitis, iritis, and iridocyclitis. Besides that, it can be found in the topical formulations to treat any dermatological diseases such as dermatitis, mycosis fungoides. They also can be presented in the inhaled formulations to treat respiratory diseases such as asthma, COPD, and pulmonary emphysema. In the tablet form or in the vial form, it can be used in the rheumatic disease and rheumatic autoimmune diseases.